There are things like chromosomal abnormalities, risk of trisomy 21. There are genetic mutation carriers like cystic fibrosis, sickle cell anemia, for which a mother might not know that she carries the mutation, but should she partner and mate with father who has the mutation, it confers risk to the fetus.
Hello, everyone. This is Dr. Lwanga. I have my friend, Dr. Heather Stanley-Christian, who's a maternal-fetal med specialist. We are in for such a treat. I'm so excited to interview her. I have so many questions. We were talking before we started recording, and she said something that blew my mind. And I'm like, I need to start recording right away before we go into a complete different area and we miss capturing so many of the important things she has to say to us. Dr. Heather, please, tell us a little bit about yourself. Tell us a little bit about your journey in medicine and how you decided to specialize in maternal-fetal medicine.
Good morning, everybody. So I was a child nerd. So from the age of 10, I actually wanted to do medicine. It was funny. I wanted to teach and I wanted to do neurosurgery. And so my focus going through school was geared towards getting into medical school. I had my son 11, 12 months before I entered medical school. That's a whole different thing by itself. And as I was going through the process of going into med school, I thought to myself, I loved my OB, but I was strategizing and putting myself at the other side of the table. Long story short, I entered medical school, kept my mind open to all of the different specialties except pediatrics, and decided that OBGYN was the best fit for me. So I went through OBGYN and then landed on maternal-fetal medicine, which was actually my second love. Gynecology was my first love, but that was just too hard a subspecialty to really work in for me personally. So here I am in maternal-fetal medicine, and it's been great ever since.
Wow, you have had such an incredible journey. I can't imagine, like med school is enough. And then going through med school with a child, like I can't imagine how challenging that must have been. But not only to do that, like for our audience, they don't necessarily understand the medical journey. There's medical school, and even before medical school, you're doing some undergraduate work. And then OBGYN residency is not easy. And then you do maternal-fetal med as a subspecialty. So I can't imagine, you are definitely a very strong woman. For our audience who have never heard of maternal-fetal med, could you explain that a little bit more to us? Tell us, what do maternal-fetal med specialists do? What is their role in the medical field?
Okay. So maternal-fetal medicine specialists are actually consultants to the obstetrical OBGYN doctors and OB providers like the nurse midwives and family practice and those who are not board certified in the American Board of OBGYN. So that is our baseline training. Then we spend 3 years to subspecialize and find our niche in medical surgical complications of the mother as well as the fetus. So we have actually two patients. We have the one that we can see, feel, touch, hug, and cry with. And then we have the onboard one that we have to figure out in concert with mom's physiology and complete state to bring that mother-baby dyad to a hopefully nice outcome of a pregnant and a baby and a healthy mom, despite what her disease status is coming into the pregnancy. So that's our focus.
And how, on average, how many years does it take to specialize in maternal-fetal med? Say you're in high school and you're interested. How long of a journey would this be?
Okay, so you have to start off with going into college, getting the credits, getting into med school, which is 4 years if you're US based. Then you have to apply for the OBGYN residency, which is another 4 years. And then you have to apply for the fellowship, which is another, so the maternal-fetal medicine fellowship is 3 years.
Yes. And I think you also focus on genetics as well, if I'm not mistaken.
Yeah, that's right. So I nerded out while I was in the throes of my maternal fetal medicine training. Clinical genetics has a huge overlap in the mother baby space because there are conditions that may be known to the parents or may as not yet be known to the parents, because we've had that opportunity to give a diagnosis and tell them what the diagnosis means. So yes, so I went and then subspecialized in clinical genetics for another 3 years, but I did it in a creative way where it actually shaved a year off. So instead of spending 6 years in 2 fellowships, I ended up doing a combined fellowship in 5 years that was prior to the official combination that the American Board of OBGYN allows now.
Wow, that is incredible. So, what also drew you to genetics? I'm intrigued because this is not a typical journey. Please tell us. What drew you to genetics as well?
Oh, curiosity, I think, more than anything else. So, part of the thing of maternal fetal medicine is that one uses an ultrasound to look at the second patient, the baby. And sometimes you put the probe down and you see some anomalies of certain organ systems. And it's our nature to combine one abnormality. You go, oh, okay. But when you start to see 2 or 3, you kind of wonder if there's a pattern or a syndrome. And so I found myself naturally drawing towards that. And it just made sense that I would have formal testing, because doctors, if we have a natural inclination to something, we want to certify the heck out of the letters behind it. And in truth, I could have done the clinical genetics training like a lot of other MFMs do without going to the NIH to get a board certification. But that was just how my brain was wired at the time.
That is amazing. That is amazing. And I suspect you're probably one of a handful who've gone that route. That requires a lot of dedication, but I commend you because they are connected. And from my observations, during med school, I did extra rotation in maternal fetal med, and I found it so fascinating. It's like a field that also, at least from my assessment, I might be wrong, there's a little bit of radiology in there because you guys are looking at scans. There's, to me, a lot of internal medicine. I found there's a lot, in my thoughts, I thought there's a lot of overlap with internal medicine.
Absolutely. It's internal medicine, it's radiology in the terms of the ultrasound, because a lot of us focus on the fetus. So we're doing the ultrasound of the fetus, but sometimes you can see pathology in the mother, because as you're doing that, like we just not too long ago saw a mom who we gave her the diagnosis of polycystic kidney disease just by being nosy and extending out. We saw the cysts in her kidney, and it opened the portal for a different diagnosis and treatment and all of that. And then you can have critical care, because there are a lot of conditions that can put a mother in the ICU. Mother's physiology is different when she's pregnant than when she's not. And so there's a space for that. You name it in medicine, there's a space for maternal fetal medicine in there. I personally like the internal medicine, genetics, ultrasound part of things.
Wow. That is so fascinating. I didn't realize the whole critical care bit, but it makes sense because unfortunately, pregnant women can end up in very challenging situations and in the ICU. For our audience, what are some of the conditions or what are some of the circumstances that would lead an OBGYN to refer their patient to see you?
A lot of that is dependent on the comfort level of the OBGYN. For example, chronic hypertension. So if you're coming into a pregnancy with a long history of elevated hypertension or diabetes, there are obstetricians who are comfortable managing that, and there are some who are not. So they may at least get a minimum of consultation, because there are certain things like, what medications are you coming in? Are you pregnant on certain medications which are not good for the baby? What is your hemoglobin A1C? So that's your average glucose value prior to getting pregnant. And that becomes important because by the time we as women realize that we're pregnant, the heart and the spine are already formed. And so if you're coming in, like I had a lady I was just talking to last night, her hemoglobin A1C was 9, and she thought that her diabetes was in good control. And I'm like, no, mama, there's room for improvement. And this is why. So in cases when a woman does her first prenatal visit and that obstetrician identifies that this is an at-risk or high-risk condition, at a very minimum, they may send the patient for at least a consultation. There are other doctors or providers who might require or desire co-management. So the MFM would manage the high-risk condition, but the obstetrician will do the routine prenatal care and the delivery. And under special circumstances, if things are just too high risk, then the mom might be transferred to an MFM that does the entire scope of care, the prenatal visits and the high-risk conditions and the management of deliveries.
Very fascinating. I have so many questions and there's so many different directions I want to go in. But before I forget, I want to ask you, before we started recording, you said MFM, maternal-fetal med, begins with the thought of conception or something similar. So I wanted to ask you, what do you mean by that? That is a big statement on its own, and I have my assumptions, but I want to hear what you mean by that statement specifically.
So for me, I have evolved during my care of our ladies. I started to wonder, I was like, oh my God, wouldn't it have been so amazing if before the woman got pregnant with her hemoglobin A1C of say 12, that she came in prior to getting pregnant and we worked on lowering that average glucose value, because then it primes her entire body and therefore optimizes the maternal temple so that this baby can be received, this embryo can be received, implanted, nourished, and the organogenesis, the formation of the organs, are done in a way where there is not, and it's hard enough being an embryo, implanting, and doing the things that you need to do on an ideal basis. And so when you have a mom who has some medical condition that has great impact on the pregnancy, it makes the work of this little one a lot harder. If the thought of getting pregnant occurs, that's where I think maternal-fetal medicine should start. Now, I don't know that all of MFM agrees with me on that. I think on some level they would say, yeah, true. Some of us would say we don't practice embryonic medicine. We practice fetal medicine. So that's after 12 weeks. But in my career, I think I've evolved into the whole being fertility awareness because it makes such a difference. There's no doubt. We know this.
100%. And I think the challenge also comes with the healthcare system, because from the baseline, it's very difficult, first of all, to find a primary care provider. So if you are able to see maternal-fetal med early, that's amazing. But at the end of the day, all the specialties are connected, and the woman as a whole, whether she's pre-pregnancy or during the phase of being pregnant or even post-pregnancy, there's a lot of challenges that come with that.
Yes.
The first few weeks and post-pregnancy, definitely the whole life cycle is connected. And then another question I wanted to ask you is about genetic counseling. So say a woman is generally healthy. Should she be asking her primary care provider or even her OBGYN to refer them to see you for genetic counseling? Or are there specific situations where they should be seeking genetic counseling?
It depends on who their provider is. For a woman who has no family history, when we do the family tree to 3 generations, we don't identify some patterns that are suggestive of a genetic condition. Absolutely, they can talk to their OB provider or OB doctor, because there are things like chromosomal abnormalities, risk of trisomy 21, trisomy 18, 13. There are genetic mutation carriers like cystic fibrosis, sickle cell anemia, spinal muscular atrophy, for which a mother might not know that she carries the mutation, but should she partner and mate with father who has the mutation, it confers risk to the fetus. So that kind of baseline genetic counseling, preconceptual counseling, can be done in the office of the primary care provider or the obstetrician. That's something that I think most doctors feel comfortable doing. Now, if there is a pattern of, like for the example I gave, polycystic kidney disease, because my lady who was diagnosed, when I was talking to them, the mother had it and didn't know that it was an inheritable condition. Now, I would say, yeah, because when we see a patient for the first time, we should be doing a family history. It's a thing that maybe fall into the wayside, but that is the importance of the family history. So if that family history had been obtained, that person would be now selected to go to a genetic counselor or even a maternal-fetal medicine specialist. Some don't like the preconception counseling because their focus is maybe on critical care or other things. But there's somebody, one of us out there. Hello, I'm Dr. Stanley. I love the preconceptual counseling. Come on over. Let's shake the tree. Let's look at things. And let me tell you what I think your risk is going to be and how you want to address it, because there's so much information there. So in regeneration, it means the mother, the sibship, and any offsprings. So those 3 generations. And if you have the maternal or parental lineage, that's informative as well.
Okay, so if there's some kind of condition, they're not sure if it's genetic or not, perhaps in that situation, they should be referred to you for prenatal counseling. So for our audience, is that correct?
Correct. Yes. You don't have to know that it's a genetic thing. Just say, oh, my mother's mother has a condition, or she has B eyes or whatever. Put it down, and we should be able to look at it and say, okay, let's explore this further.
Okay. And then the next question I want to ask you, for those who are definitely not in the medical field, that ask, so what is prenatal counseling? What does that mean? What is the benefit of having counseling before conception if there's suspicion of a genetic condition or there is a confirmed condition that runs through different generations?
Okay, so preconceptual counseling can be focused insofar as the parents have a specific question about the family history and they want to just focus on that. Or preconceptual counseling can be more broader, where we do a very focused. So I'm going to tell you, when a patient comes for preconceptual counseling, even if they come for this particular condition, I'm doing a very detailed history, toxins, family history, medical history, all the things. I'm quite nosy because I think about it as like CSI, because I need to put the things together. And so at the end of that, now I create a risk strategy. So if they thought that they came in for example, a clubfoot, which is one of the most common malformations that newborns have, and in the history, it's just that baby or a cousin third removed, it's very likely not a familial thing like an unknown gene passing through the family. It's probably just a 1 in 2,000 incidence that's causing that issue. So I'll stratify that risk as low and then counsel them, educate, tell them how we diagnose it when in the pregnancy, because we can see that on ultrasound earlier in the pregnancy. And then if I say, oh, by the way, I see where you have 3 miscarriages, or you've been trying to get pregnant for the last 16 years and you've been going to these doctors. What are you doing? You're approaching 35 or you're 45 and you're thinking about getting pregnant. Let's put that at a higher risk strategy, because we know our eggs age out. We don't make our eggs according to when we're ready, like the guys do. Larry King, children at 88. We won't talk about the quality of the sperm, but he can do that. We don't have that benefit. So if you're thinking about getting pregnant and you're 35 and you've been trying, or you've not been using contraception for 2-3 years and nothing's going on, it's time to press pause and ask, what's going on? One of the things that I see is that the ladies, they skip from gynecologists to primary care, and our information system in the healthcare spaces does not communicate. So she goes down the road to one doctor. She goes to another state to another doctor. And then before you know it, time has passed. Eggs have passed. And now she's looking at menopause and wondering what she needs to do. And then we find out that there are some things that have to be taken care of. So we're now racing against the clock. So that, I think that is actually my sweet spot, is to get these ladies before they're like 44 and, oh my God, I want to have a baby. And we're trying to sometimes create miracles, and then they end up at the infertility specialist with IVF.
So I have so many questions, but I think I need to focus. You said so many things. So maybe the first question I'll ask is REI, reproductive endocrinology and infertility. Do you guys tend to work together a lot, or does your specialty overlap?
Yes, it does. It should theoretically overlap at the time of we're going to get pregnant, because some infertility centers will send a woman for clearance with maternal-fetal medicine as a preconceptual counseling. I've worked with a couple of infertility centers like that, and I love that. In the pre-pregnancy phase and the embryonic phase, we work together, and then the infertility specialist will release the patient after 6 weeks of pregnancy. And then depending on what the risk factors are remaining, she may go to an OB doctor or co-manage with an MFM, because this puts a new definition on precious pregnancy. All pregnancies are precious, but when they're going through the procedures and the cost associated with infertility treatments, you really want to make sure that your providers are minding the store very well.
The other question I wanted to ask you, which is a little bit off tangent, but it's something you mentioned before when we were talking. You mentioned maternal-fetal med specialists also do a lot of critical care work. Tell me a little bit more about that. In what circumstances would, say, an intensivist call you to help? What do you do? Or when you are in the ICU, if, say, a patient has a certain condition? I'm curious.
Yes, so that is so not my wheelhouse. While I like it, it stresses me out. So there are conditions, the most common one that we see, and we're unfortunately hearing in the news, is the sepsis. A pregnant woman, their immune system is not as robust as it should be. And that is because the baby is half foreign. So in order to keep the pregnancy to its conclusion, the immune system has to deal with the fact that there is a half foreign entity in the body. So the immune system is dampened. Unfortunately, that sets a pregnant woman up for infections. If membranes are broken before the baby's at a viable age, that is a big conduit set up for infection. So if there is a clear indication that this woman has to be in the ICU, that's one of the conditions. Now, the physiology of the female body in pregnancy is very different. All the parameters, I think the intensivists love fibrin split products, for example. That means nothing in pregnancy. So unless an intensivist has a special focus on knowing the physiology of pregnancy, this is where I would encourage intensivists to invite a maternal-fetal medicine specialist, doesn't have to be critical care, to come in and help them interpret the numbers in a way that's meaningful. The critical care obstetricians or MFMs tend to be in the larger hospital systems, so it's very easy to find them. So that would be one condition. And then there's a rare fetal condition where if there's a tumor, sacrococcygeal teratoma, which is a big tumor on the butt of the baby, it can steal blood from the baby. It can make the baby very hydropic, which is an abnormal amount of accumulation of fluid in the baby. There's a condition called mirror syndrome where the mother starts to mirror what's going in the baby. And that can cause severe consequences for the mother. So that's a rare, but another indication of where after we deliver the baby, we might put mom in the critical care to manage her fluids, because she's now mirroring what the baby was doing, and we have to support her through to when she goes back to her normal baseline.
Wow, that is so fascinating. And even just thinking back to my training, when I was doing ICU as an internal medicine resident, there were a few situations where pregnant women unfortunately ended up quite sick in the ICU and on a ventilator. And I remember my attendings, those are supervising physicians, definitely how concerned they were and how you could almost sense the anxiety or the fear, which I think was warranted, because you're not just dealing with a mother, you're dealing with an unborn child. And this is an area that you're not necessarily familiar with in terms of the physiology. Thank you for explaining it that way. I think that explains the trepidation and the anxiety. And definitely I remember seeing a lot of different specialists, like they'd call every single specialist A to Z to come and make sure that, that we're doing everything that needs to be done, which is absolutely warranted. I still have so many questions for you. Too many questions. So I am gonna have to have you back, because even as an internist, I have my own questions, my own curiosity. But in order to respect your time, I think we're gonna wind things down. But I want to have you back, and I have 1,000,001 questions. And if there's anything interesting that's new, up and coming, and you want to share it with our audience, we'll definitely have you talk about that next time. In terms of people finding you, where can our audience find you? Are you on social media? How can they find you?
I am. My brick and mortar office is actually in Claremont, Florida. My online presence, my website is unitymfm.com. My Facebook is unitymfm, and it's the same. I'm slowly on the TikTok. I'm getting with the program. But I am on Facebook, on LinkedIn, unitymfm. Or you can just find me, Heather Stanley-Christian, MDPA. You'll find me. But yes, I love what I do. When it's good, it's very good. And it's a sense of satisfaction, at least for me, when I see the little aha bulb in my patients, because I'm very big on teaching them about their disease and teaching them how to advocate, not even just in the pregnancy, but after the pregnancy, because you know what? You're going to come back for number 2 and number 3. And then we're going to be like Groundhog Day, where we can do something different after pregnancy, number 1, to improve pregnancy number 2. Yeah, that's my jam.
Awesome. Thank you so much for agreeing to talk with us and for agreeing to be on our show. We'll make sure that we put all the links to your website so that people can find you, and your TikTok. And I think now our audience will be following you on TikTok. So we're excited to see.
Yes, I'm slowly getting into there already. I'm like, you can teach an old dog new tricks. And so if we don't grow, we die in the vine. So TikTok, here I come.
Absolutely. Just rinse, repeat, remix, and just put the same thing there. So important, because the world that we're living in, people are using Dr. Google, Dr. TikTok. So we need to be out there and let them know this is maybe not the right thing to do. Maybe this is the right direction to go in. And I think somebody was telling me that the next Gen Z is using TikTok to research stuff more than Google, which is, I think it's scary, but we have to be there to make sure that people know the right stuff.
Yes, absolutely true. Absolutely true.
Yeah, but thank you. Thank you again for agreeing to be on our show, and we will have you back for sure.
Absolutely. Thank you so much, Dr. Anita. I appreciate the opportunity to talk to your audience, and I wish you happy holidays.
Yes, thank you. Happy holidays to you too.